Bismillahirrahmanirrahim. Welcome guys. So in this video, we will discuss about how to take a diabetes history from a pregnant woman. This is the simplest and the easiest template. First of all, always inquire about the biodata, then go through the presenting complaint. In the diabetes with the pregnancy, patient can be admitted with any of the following complaints, either the new onset diabetes leading to the symptoms of polyuria, polydipsia, polyphagia, or uncontrolled diabetes level and rearranged basal levels on the home record, diabetes complications, either polyhydramnios, macrosomia, intrauterine death, or complaint of recurrent urinary tract infection. Inquire about the date of admission and the mode of admission, either admitted to the OPD or emergency. In the history of presenting illness, ask about the details of the diabetes, which includes onset, duration, type of diabetes, either type 1, type 2, maturity onset diabetes of young, and how it was diagnosed. Inquire about the hypoglycemic agents, the type of the medication patient is taking, its dose, compliance, a very important thing to ask, the side effects. If patient is taking insulin, inquire about the units, timing, type, of insulin, whether regular or NPH, the site of injection, and lipodystrophy on the injection site. Inquire the patient regarding whether she checks her BSL level frequently or how often. Are the levels controlled or uncontrolled? Is there any episodes of hypoglycemia she felt? Like inquire about the symptoms that are syncope, dizziness, sweating, palpitations, lethargy, and BSL levels. Inquire the patient whether she has undergone any preconception counseling or any medical visit to a general physician or her medical doctor endocrinologist to ask about whether she can conceive or not, whether her diabetes was controlled before conceiving, whether her drugs have been changed by her doctor, HbA1c done in the last 3 months or not. Ask the patient how much diabetes has affected her quality of life. Then comes the complication. Quickly go through the complications. Inquire the neuropathy in the form of either complaint of numbness, burning sensation, or tingling in the hands and feet. Nephropathy, inquired pedal edema, facial puffiness, decreased urine output, foamy urine. Any investigations done related to that nephropathy, which includes urine incomplete examination and RFTs, renal function test. Inquire about the vasculopathy in the form of diabetic foot and a history of hypertension and ischemic heart disease. In the retinopathy, inquire the patient the symptoms related to the blurring of vision, blindness, flashes of light, which means scotoma, and any fundoscopy done in the last 6 months or not. As the diabetes causes gastropathy, inquire about the complaints include the flatulence, heartburn, abdominal pain, and nausea. Ask the patient regarding recurrent urinary tract infection. Inquire the symptoms, dysuria, increased frequency, urgency, or urine complaint investigation done or not. Inquire the patient regarding recurrent vaginal infections in the form of a type of fungal infection. Then comes the fetal complications. Ask the patient regarding polyhydramnios and macrosomia in the terms of sudden increase in abdominal girth and increased amount of liquor are told to the patient on the scan. Any discomfort or any shortness of breath to relate the category and the severity of polyhydramnios. If diabetes is included with the vasculopathy, then inquire about the intrauterine growth restriction and it is spiky on the scan. Ask the patient, has any doctor told her, is there any growth disparity on examination or on scan? Then go through the trimester-wise history quickly, which I have already told in the previous video. If the patient is admitted, so inquire these following questions for during the hospital stay. What treatment she has taken, what effect of that treatment, whether the heart levels are controlled now or not, any regime change from the previous one, her basal level monitoring and the timings, whether the basal levels are controlled or not, are the fasting levels, pre-meal and post levels done or not. Ask about any hypoglycemic episode with the new regime. This is a very important question and comes in the patient safety. Inquire about any side effects of that particular regime used, whether she has been given the diet chart or not, and whether she is following that diet chart. Compliance of the diet chart as well as medicine is important to ask. Latest scan done and the findings of the scan if the patient knew that. Discuss the mode of delivery if the patient is approaching at term and ask for the steroid cover if given or not. In the OPS history, inquire about the previous history of gestation and diabetes, previous history of macrosomic baby, intrauterine death, congenital malformations, miscarriages, shoulder dystocia, or history of neonatal ICU admission. In the gynae history, inquire the patient regarding the mode of contraception she has been using until her physician has suggested her to conceive. In the past history, inquire about diabetes, hypertension, thyroid disease, if there is a diabetes type 1 because autoimmune hypothyroidism is associated with the type 1 diabetes, and history of poor wound healing if any after any surgery or any scar mark. In the drug history, if not asked previously, ask about the hypoglycemic agents she is currently using or has been used previously before pregnancy, any drug reaction or the side effects. Family history of diabetes in the first degree relative is important. Personal history, inquire about the dietary habits. If you know, and the patient also knows that this is gestational diabetes, so you need to ask the following points in the history, which includes how the GDM has been diagnosed, either by her symptoms or and then OGTT has been done, and when was oral glucose tolerance test was done. Is there any complication associated with the GDM, which includes polyhydramnios and macrosomia? And any complaints or symptoms of diabetes, new onset diabetes, which can be either polyuria, polydipsia, and polyphagia, glucosuria on any during complete examination done, the level of basal monitorings, the treatment taken or not, and the rest of the history trimester wise and during admission is same. However, in the past history, inquire about the previous history of diabetes, macrosomia, polyhydramnios, and intrauterine death. In the family history, inquire about the first degree relative with diabetes. This is the modified White classification system, and it classifies the diabetes. A1 class belongs to the diabetes, which is diet control. A2 belongs to the GDM requiring insulin. B, C, and D class belongs to the different category associated with the onset and duration. F class belongs to the diabetes with nephropathy. R belongs to retinopathy. T belongs to renal transplantation, and H belongs to the cardiovascular disease. These are the risk factors for the gestational diabetes according to the NICE guideline, which includes BMI more than 30 kg per meter square, previous macrosomic baby 4.5 kg or more, previous history of gestational diabetes, family history of diabetes in the first degree relative, more importantly, mother or sister, minor ethnicity, which includes South Asian in Pakistan, Black Caribbean, and Middle East. So these are the risk factors by which you will screen the patient with the diabetes. This is the easiest most template of diabetes in pregnancy, and you can now master this history by the end of the video, hopefully. For more updates, subscribe to the channel. Thank you and good luck.